enhance his cardiology knowledge and presented cases to experts in the field. He is very interested in academics and research and has multiple publications in various journals. And he's a very humble person. This is something extra which I wanted to add here. Dr. Ramakrishna, over to you.
Thank you, Dr. Santosh, and thank you, Dr. Shyam and organizers for giving me this opportunity. And today we'll briefly discuss about what are the cardiovascular complications of diabetes, and it's all why it is important to know about cardiovascular complications, because this is the number one killer in diabetic population, and what are the various ways it affects your heart we'll discuss in the coming slides. And cardiovascular defect diseases are twice more common in diabetics compared to the general population, and it is also 2 to 4 times increases the risk of cerebrovascular accidents, that is stroke. And if a person once have a stroke, it's almost double the risk of having a recurrent stroke, especially in diabetics. And other important aspect of cardiovascular disease is it affects at an early age. And nowadays, we are seeing people with heart attack at the age of 30, 32, or sometimes below 30 years. And one important risk factor among all these youngsters is diabetes. And these are various ways of diabetes affecting your heart. That is, the number one risk factor is ischemic heart disease. That is development of coronary artery disease because of accelerated atherosclerosis. And other important aspect of this is heart failure. With various reasons, the heart pumping gets affected. That is low ejection fraction, or it may be diastolic dysfunction. Another important part of these cardiovascular risk is stroke, and the other important risk is peripheral artery disease, maybe because of diabetes or with accelerated atherosclerosis in this diabetic population. So I will briefly show you some of the case examples. This is a 52-year-old male diabetic patient, and he's for diabetes duration is 10 years, and he presented with one episode of TIA 1 week back, and at the same time he had retrosternal chest pain, and at this ECG showing dynamic changes in the anterior leads, and we did coronary angiogram and cerebral angiogram for this patient. This in this I think this you can see there is a tight stenosis of the internal carotid artery, and because of this patient developed some transient ischemic attack. Luckily, he escaped major stroke. Suppose if a person of this tight stenosis, he develops complete occlusion of this vessel, and complete cerebral hemisphere will get damaged, and he will land in major stroke. And you know, it's the morbidity and mortality with the stroke is very high if he develops this sort of large stroke. It's not a like microembolic, it's like major. One complete cerebral hemisphere gets affected if he had major stroke in this patient. And for this patient, we did intervention, and you can see here, some pointer is here. You can see here we placed a filter in this because this is very high thrombotic. This white thing is thrombus. We want to protect the thrombus to migrate into the cerebral, the brain. So we placed a filter above this, and we did intervention for this patient. We placed a stent here, and immediately after stenting, the entire vessel went into spasm. Patient developed on table some altered sensorium and loss of sensation on one side. And luckily, within 1-2 minutes, and he recovered, and these cerebral vessels are protected now. And he did not develop any stroke after 48 hours also. So this is one staring example of this stroke in diabetic populations. And we did stenting to LAD also because he also had left-handed LAD stenosis. And this is another example of 63-year-old male diabetic patient since 13 years, and he presented with non-healing ulcer of the left great toe since 1 month. So he doesn't have any cardiac symptoms. No chest pain, no breathing difficulty, and no other comorbidities, no hypertension, no smoking, nothing. Only diabetes and risk factor. If you see his coronaries, and there is diffuse disease in the if you see his coronaries, there is a diffuse disease in the LCX. This is the coronaries on the left side. That is, the upper one is left anterior descending artery and the lower one is left circumflex coronary artery. You can see diffuse narrowing at multiple levels, not at one level. So this is typical of diabetic disease, diabetic coronary artery disease. And he also had calcification in the entire LADs. And similarly, this patient also had a right-sided blood vessel. That is, all the three vessels are significantly getting affected. And at the same time, we did the peripheral angiogram of this patient. And we injected the contrast in the left common femoral artery. And you can see there is complete occlusion of the superficial femoral artery in this segment. You can see here, from here onwards, there is diffuse atherosclerosis and there is complete occlusion of this. This is the right side coronary artery. There is narrowing of the coronary artery from here to here, and the lower portion is relatively preserved. And if you see the leg vessels, this is the complete occlusion of the superficial femoral artery. This is below knee. This is anterior tibial and posterior tibial arteries are completely occluded, and because of this ischemia, he developed ulcer. And this is the complete occlusion of the superficial femoral artery from this short segment. And for this patient, we did stenting from here to here. So with that, the flow is reestablished and this leg wound has healed completely within 2 weeks. And he also had disease on the right side also. And another patient is a 57-year-old female, and she is diabetic since 8 years. She had chronic myeloid leukemia. She is on nilotinib, that is the chemotherapeutic drug, since almost 4 or 5 years. She presented with breathlessness 6 months back, and her ejection fraction is less than 20%. She presented with heart failure, and we stabilized her. After stabilization, we did angiogram for this patient. And you see, this is the LAD, the upper one is LAD, and this is the circumflex coronary artery. You can see narrowing in the LAD. This portion is very tightly narrowed, and you can also see this is in the LCX here, and this is the OM1 branch here and OM2 branch. And if you see LAD in other angle, there is a diffuse disease in the LAD from here to here, and you also have a disease in the diagonal. So it's not like at one place discrete stenosis, it's like diffuse disease affecting entire vasculature of the heart. So similarly, this patient also had right side where blood vessel is totally diffuse narrowing from in this segment and in this segment. This patient ultimately requires bypass surgery because of effect of all the three vessels and at multiple levels, not at one point. So why we should know this? Because diabetes and cardiovascular disease share common risk factors like unhealthy diet, lifestyle habits, obesity, smoking, and both these contribute to diabetes and cardiovascular disease. And diabetes itself is a risk factor and cardiovascular risk multiplier. And we all know that diabetes is a progressive disease. As the duration of the diabetes increases, there is increase in risk of microvascular and macrovascular complications. If you see the microvascular complications, they start appearing once the patient reaches the threshold of diagnosis of diabetes. But the macrovascular complication starts appearing before the diagnosis of diabetes. Suppose mildly elevated sugars or impaired fasting glucose tolerance. All this acts as a risk factors for development of macrovascular complications, especially cardiovascular diseases. So this is one of the oldest study, and the two is a 20-year follow-up of 1,21,000 women, that is nurses health study. If a person doesn't have a diabetes, the risk of developing MI is less, and at the diagnosis of diabetes, the risk is almost doubles. And if the person had diabetes at the diagnosis of MI, the risk is almost 5 to 6 times. So diabetes plays an important role in cardiovascular morbidity and mortality. Suppose if a person have a diabetes of duration of more than 15 years, his risk is equivalent to already had one-time heart attack. One-time heart attack is a predisposer or risk factor for development of second-time heart attack. So this risk is almost 8 to 10%, even if the person is equal to non-diabetic patients. So if you compare various randomized trials, diabetes almost doubles the risk of each and every major cardiovascular disease like coronary death or non-fatal MI almost double. The hazard ratio is nearly equal to 2, and stroke, ischemic stroke, hemorrhagic stroke and unclassified strokes also relatively double in diabetic patients when compared to non-diabetics. So what is the pathophysiology of this? You all know that diabetes is insulin resistant state, and even the cardiovascular risk factors increases with insulin resistance. The other important factor for development of cardiovascular disease is inflammation, diffuse inflammation in the vasculature, whether it may be cerebrovascular, cardiovascular or peripheral vascular, that is diffuse inflammation. And the oxidative stress and hypercoagulability. If you see platelet reactivity of diabetic patients with CVD, there is hypercoagulability and hyperaggregation of the platelets even before development of occult cardiovascular disease, the prompt cardiovascular disease. And other important shared risk factors among these patients is high blood pressure, dyslipidemia and obesity. The dyslipidemia is typical in diabetic population, that is the excessive small dense LDL. Even though LDL is less by lab values, but the small dense LDL particles are high and they have typical hypertriglyceridemia with low HDL cholesterol. That is called diabetic dyslipidemia. And this small dense LDL is highly atherogenic compared to normal dense LDL. So insulin resistance is the central mechanism for the vascular complications that is leading to endothelial dysfunction and decreased vascular reactivity and increased vascular inflammation, thereby progressing the atherosclerosis. So what is the benefit of lowering blood glucose? We have to, these are the almost 20-30 years studies, and they have shown that aggressive blood sugar control, that is reduction of HbA1c in the tight control range, they have shown there is a significant reduction of the microvascular complications, retinopathy, nephropathy, neuropathy. But macrovascular complications are reduced after delayed effect, that is after 20 years. So you need to have a tight control of blood sugars and HbA1c from the beginning of the diabetes. So these are the some of the landmark trials, that is UKPDS trial. You all know that there is a 15% reduction in the MI and 13% reduction in the all-cause death with intensive glycemic control at 10 years follow-up. But afterwards, there is randomized studies, that is advanced ECAD and VADT trials. They studied more than 23,000 patients. They studied the effect of reduction of the HbA1c on cardiovascular mortality. In these studies, there is 1% reduction in the HbA1c, there is 15% reduction in the non-fatal MI, but all-cause mortality or overall cardiovascular death is not significant between the control and treatment arms. And after this, in 2008, the FDA has given a recommendation, the guidelines for new drug developments. Each new drug has to show cardiovascular mortality and cardiovascular safety first, and then morbidity and mortality benefit. And in this, the newer drugs are the SGLT2 inhibitors and GLP-1 receptor agonists and the DPP-4 inhibitors. So these are the newer class of drugs, and what are the benefits of these class of drugs on the cardiovascular safety we need to identify. If you compare with the placebo, the empagliflozin has reduced the overall major cardiovascular death, non-fatal MI and fatal strokes. And if you coming into in depth, so there is reduction in the overall cardiovascular death and CV death in particular, but there is no major difference with non-fatal MI, non-fatal stroke. There is maybe minor strokes and MI, there is no difference, but overall cardiovascular mortality has significantly reduced. Similarly, the heart failure patients has shown reduced number of hospitalization, and there is almost 15 to 20% mortality reduction with heart failure with this new class of drugs. And with this all-cause mortality is relatively less compared to placebo. So these patients almost more than 10 years diabetic, almost 7,000 patients are studied in the empiric study. Almost 90% of the patients had pre-existing cardiovascular disease. And this study has shown mortality benefit with all-cause mortality and CV death, but not much difference with the non-fatal MI and non-fatal stroke. So there is a reduction in the almost 20% reduction in the all-cause mortality and CV death. So other important study that studied SGLT2 inhibitors is CANVAS study, and this study also included almost 10,000 patients. Almost 60% of the patients had cardiovascular disease before inclusion into the study,
And this study also shown some mortality benefit and reduced CV death and non-fatal MI in these patients. So what are the other various landmark trials? That is uh, credence study and declare TIMI 38 study, that is studying dapagliflozin versus placebo in diabetic patients with cardiovascular risk factors. The other important group of drugs is GLP-1 receptor agonist, that is liraglutide and exenatide. So liraglutide versus CV events, this drug also shown liraglutide has cardiovascular mortality and morbidity benefit when compared to the placebo. There is reduction in the overall CV death, MI, but there is no difference in the non-fatal stroke, non-fatal MI and heart failure hospitalization. And all-cause mortality is slightly low in the liraglutide group. So other important class of drugs is DPP-4 inhibitors. So these drugs are, we can say it's a cardio neutral. So they don't have a increased risk of drug-induced heart failures, but they have a cardiovascular neutral benefits. So these are some of the trials, that is Carolina and Carmelina studies. They have shown there is no significant difference. If you see hazard ratio, it's almost equal to 1. So it's like cardio neutral drugs. So meta-analysis of these three class of drugs, there is, if you study this GLP-1 receptor agonist, there is reduced in the overall major adverse cardiovascular events in the there is reduction in the major cardiovascular events with the GLP-1 receptor agonist, SGLT2 inhibitors, but DPP-4 inhibitors are cardio neutral. And even the non-fatal myocardial infarction is slightly reduced with the GLP-1 receptor agonist and SGLT2 inhibitors, but there's DPP-4 inhibitors are, they're cardio neutral but cardio safe. And non-fatal strokes also, they similarly similar between SGLT2 inhibitors and DPP-4 inhibitors, and GLP-1 receptor agonists are slightly more favorable in this aspect. And overall cardiovascular mortality benefit with GLP-1 receptor agonist and SGLT2 inhibitors, but DPP-4 inhibitors are more or less cardio neutral with slight benefits. And not only the controlling of diabetes, and we also need to look at the other contributing factors for cardiovascular disease, that is reduction of the cholesterol and control of blood pressure and the use of newer drugs and aspirin based on the selective use and lifestyle modification. That is the four most important in reduction of all these events like regular exercise, diet and weight reduction. And we all know that statins has shown major cardiovascular benefits in major trials with or without diabetes, especially with diabetes. The statins has a primary important role. If the patient's LDL cholesterol is more than, if the more than 70 or 70 to 190, or if the cholesterol is more than 190, you have to give high dose statins, especially in diabetic population. Even if their cholesterol is more than 100, you have to treat with high dose statins in this diabetic population, because these patients have higher dyslipidemia, diabetic dyslipidemia. Apart from statins, what are the other class of newer class of drugs? This is the drug that is ezetimibe, that selectively blocks absorption of the LDL cholesterol from the gut, and it selectively inhibits the selectively reduces the LDL cholesterol. So if you add ezetimibe to statin, there is almost 20% reduction in the major cardiovascular events at 1 month. And apart from this, the newer class of drugs, that is PCSK9 inhibitors, that is evolocumab. So that has once in a month or once in 14 days injection, that reduces LDL cholesterol by more than 50%. If the patient's cholesterol levels are not under control with statins or ezetimibe, still you need some other drugs, that is the once in a month injection of evolocumab. So you need to maintain the LDL cholesterol between below 70. So apart from the cholesterol, we need to have a tighter BP control. So this is the landmark trial. This has shown patients with uncontrolled blood pressure has higher cardiovascular events when compared to the tighter blood pressure control. That is systolic blood pressure. And why only systolic blood pressure? Even the diastolic blood pressure has cardiovascular complications. We need to maintain the diastolic blood pressure below 80, especially younger patients who have higher diastolic blood pressures like 90 or 100, but systolic pressure is around 130 or 140. In these patients also, we need to have a tighter control of diastolic blood pressure. This study has shown the tight control of the diastolic blood pressure below 80. So there is almost 50% reduction in the major cardiovascular events with tighter diastolic blood pressure control. So the other important which class of drugs we need to use? Suppose there are so many class of antihypertensive medication. So which class of drugs you need to use in the diabetic population? So there are some randomized studies. So that has shown benefits in these diabetic population. That is the ACE inhibitors and ARBs, which has cardiovascular and renal benefits, not only cardiovascular. So if you compare the in Ramipril with placebo, there is almost reduction of the major cardiovascular events, all-cause mortality, MI, stroke, and CV death. The number needed to treat is hardly all patients, all events is less than 30 or 40 like this. So you need to give this medication to save almost one life if you give like 30 patients like this. So what is the benefit of ARB? Nowadays the most favored drug is ARBs. Oh, because of little side effects with ACE inhibitors like Ramipril and Enalapril, they have cough. So majority of the patients will be on ARBs. And ARBs also had more or less same benefit. But the first line of drugs is ACE inhibitors. If the patient is intolerant to ACE inhibitors, then we can shift to ARBs. And when we should start this medication? Patient had clinical cardiovascular disease, already had one MI or peripheral vascular disease or cerebrovascular disease. In these patients, we need to give ACE inhibitors and ARBs provided other contraindications are not there, like renal failure or hyperkalemia, and microvascular complications like proteinuria, albuminuria. And what are the recommended doses? Suppose if you give perindopril, you need to give maximum dose of 8 mg, and ramipril 10 mg daily, and telmisartan you need to go up to 80 milligrams. These are the strengths that are studied in the randomized studies to have a major cardiovascular benefits. And we need to be careful, especially in pregnant women and women of childbearing age, while starting this medication. And what is the algorithm for managing these patients? If a patient's blood pressure is more than 140 but less than 160, and if the patient is diabetic, you need to select one agent. Like if the patient doesn't have albuminuria or CAD, you can start ACE inhibitors, ARB, or calcium channel blocker or diuretic. If the patient had any of these like microalbuminuria or already a clinical CAD, you need to first line drug is ACE inhibitors and ARBs. If it is not under control with this, then you can add other class of drugs like calcium channel blockers or diuretics. And if the patient had CAD, you can add beta blockers. And if the patient BP is more than 160 by 100, you need to start with directly two drugs like ACE inhibitors, ARBs, or calcium channel blockers. Or the third line drug is diuretic. If the patient is not under control with any of these medications, then you can add this spironolactone. If the patient is like resistant hypertension, then you can add this spironolactone. And at each step, you need to monitor the side effects of the drugs like renal function and potassium. And what is about aspirins? Nowadays, many patients will be on aspirin. And there is a limited data. There is a controversial findings. Some of the studies have shown increased mortality with aspirin use, and some of the studies have shown benefit. And this is some of the meta-analysis of the studies. There is no overall major benefit with aspirin for major reduction of the major CV events, MI, stroke, all-cause mortality, or CV mortality. So this is the conclusion from the randomized studies. But we need to have a balanced decision of risk of bleeding and CVD protection. Why there is increased mortality with aspirin? Because aspirin produces a lot of gastric irritation. Along with diabetic drugs like metformin, it has a lot of gastric irritation, and it produces increased risk of GI bleeding. That is the only major side effect, and cerebrovascular bleeding with use of high dose aspirin. And that too, we should not use indiscriminately. We should take a balanced decision of risk of bleeding and CVD protection. Suppose if a person already had GI bleed or APD symptoms, we should be careful with starting aspirin. And when we should give aspirin? So we'll come to know after risk stratification which patient will get benefit, and in those patients we can give aspirin as a primary preventive measure. In secondary prevention, there is no doubt in that. If a patient already had CVD, cardiovascular disease, you have to give aspirin. If the patient already had stent, you have to continue aspirin. So not only blood sugar management, we need to have a multifaceted approach, like you have to control diabetes, hypertension, lipids, and weight, everything. So this is one small study, 160 patients that followed up to 20 years. There is aggressive reduction of all these risk factors. There is significant reduction in the microvascular complications and macrovascular complications too. nephropathy, retinopathy and autonomic neuropathy are significantly reduced if with intensive blood control, and the macrovascular complications like CVD mortality, MI and non-fatal MI, all these are significantly reduced if you have a stringent control of all these risk factors over a period of 20 years. And except peripheral neuropathy. Peripheral neuropathy is still, even if tight control, there is some patients are predisposing to this. So we need to identify high risk patients from the beginning. There are various criteria that is proposed for identifying high risk patients who will benefit from the multifaceted approach. We need to have patients with established cardiovascular disease comes under high risk category, or if the patient had already had target organ damage like microalbuminuria, proteinuria or renal dysfunction, this comes under very high risk category, or three or more major risk factors like diabetes, hypertension, smoking, obesity, these comes under very high risk population, or longer duration of diabetes. And if the person diabetes duration is more than 10 years without target organ damage, but other comorbidities are there, they come under high risk category. And moderate risk are other patients like less than 35 years and diabetes duration less than 10 years without any target organ damage. This comes under moderate risk category. So similarly, the ACC-AHA uses other risk calculator, that is ASCVD risk calculator, atherosclerotic cardiovascular disease risk calculator. It uses various parameters like gender, age, race, total cholesterol, HDL, and systolic blood pressure are already on drugs, diabetes, and smoker status. Based on this, they will calculate the risk percentage. If the patient's risk category is more than 10-year risk of developing atherosclerotic cardiovascular disease is more than 7.5%, those patients comes under high risk category. If the risk is more than 20%, 15 to 20%, they comes under very high risk category patients. In this, based on this risk calculator, we need to give aggressive reduction of the cholesterol. That is, we need to start hydrostatin or lodostatin based on this risk calculator. This is European classification is relatively easy for clinical application in day-to-day practice. So what are the various tests we need to have a periodic in these patients for periodic assessment is yearly cardiovascular assessment like resting ECG, and other atherosclerotic tests like carotid femoral ultrasound plaque detection, and screening for coronary artery disease. If the patient had minimal symptoms, also we need to have a at least coronary calcium scoring or CT coronary angiograph based on the symptoms, and ankle brachial index. And routine carotid intermediate thickness is not recommended in these patients. So what are the newer treatment algorithms for managing diabetes with CVD? If the patient already had atherosclerotic cardiovascular disease or high or very high risk category, and we need to give medication that has shown cardiovascular mortality benefit, that is SGLT2 inhibitors or GLP-1 analogs as a first line drug. If the HbA1c is not under the target, then you can add metformin, and if still HbA1c is not under target, you can add other class of drugs and DPP4 inhibitors and basal insulin and thiazolidinoleuins. If the patient is not having heart failure, you can start thiazolidinoleuins and sulfonylureas. If the patient already on metformin monotherapy, if not under control, you can add one of the SGLT2 inhibitors or DPP4 inhibitors based on the HbA1c target. If the patient already on metformin and atherosclerotic cardiovascular disease is there, you need to add SGLT2 inhibitors or GLP-1 receptor agonist as the first line drugs. So the SGLT2 inhibitors and GLP-1 receptor agonist as a class 1 recommendation for diabetes with CVD, established CVD, and metformin comes as a class 2A recommendation, and insulin class 2A, and the pioglitazone and dasiglucagon comes as class 3, especially if the patient had heart failure signs and symptoms. And saxagliptin is also increases the risk of heart failure hospitalization, so we should not use it nowadays. It's not available, I think. So what are the individual blood pressure targets? So it's not like blanket treatment for everyone. We need to have a individualized, personalized approach for young patients. If the patient BP is more than 130, and we need to bring it below 130 for especially with younger patients. And in older population, we need to have a less tight control like 130 to 140 is okay, and you need to have it diastolic blood pressure also should be less than 90. So we need to have BP management, same lifestyle management, dietary control, and renin-angiotensin receptor blockers or ARBs comes as the first line drug, followed by calcium channel blockers. Based on the BP level, you can add the second line drugs, and home BP monitoring is recommended. And the cholesterol levels, similarly cholesterol levels, if the person comes under very high risk, already had atherosclerotic cardiovascular disease, you need to maintain his LDL below 55. And if you had high risk, like you had diabetes and other like other risk factors like diabetes, hypertension, microalbuminuria, you need to maintain the cholesterol, LDL cholesterol level below 100. So coming to the what are the newer recommendations for revascularization in these patients, like the PCI or CABG, there is no difference with the diabetes and non-diabetic, but based on the vessel anatomy and complexity of the lesion, and we'll discuss in this coming slide. Suppose if the person had one vessel or two vessel CAD and low complexity, that we calculate based on the syntax score, depending on the calcification, bifurcation lesion. There are various scoring systems. That is, syntax score is one commonly used scoring system. And if the person had one vessel or two vessel, not a proximal, that is ostial LAD lesion is not there, then PCI is preferred. If the person one vessel, two vessel CAD and proximal vessel lesion, that both are equal, that is CABG and PCI. If the person had left main disease with less complex lesion, you can PCI or CABG, both are equal. If the person had triple vessel disease with complex lesions in the LAD, LCX and LMCA, then CABG is the preferred option when compared to PTCA, that is stenting. And drug-eluting stents are preferred over bare metal stents. Nowadays, we hardly use bare metal stents. And the heart failure medication, we have another lecture, and we need to have the drugs that have shown mortality benefit in heart failure is, that is SGLT2 inhibitors and metformin, and DPP4 inhibitors we need to be careful, and the pioglitazone and rosiglitazone we should not use if the patient had diagnosed heart failure. And what about aspirin? Aspirin is not indicated in each and every diabetic patient. It is indicated in selected group of patients with high risk features. If the patient already had coronary calcium scoring more than 400 or established atherosclerotic disease, already MI or any microalbuminuria, in these patients there is a selective use of aspirin with careful monitoring of bleeding risk from the GI. So if the person is on aspirin and if he is high risk for bleeding, then we need to use proton pump inhibitors. And with continuation of dual antiplatelet, that is aspirin and clopidogrel after stenting, especially in the normally we continue up to 1 year usually, that is as per guidelines. After 1 year we can shift to either aspirin or clopidogrel based on the patient risk of bleeding. Especially in diabetic patients, we need to there is a benefit of continuing the DAPT, that is dual drug, beyond 3 years too. So coming to management of arrhythmias, if the person had atrial fibrillation, then we need to the Novax are preferred, that is rivaroxaban or apixaban or dabigatran, when compared to the warfarin or acetram. So management of arrhythmias, if the person had frequent ventricular premature contractions, we need to look for structural heart disease or any atherosclerotic cardiovascular disease. And hypoglycemia should be avoided because hypoglycemia is predisposer for arrhythmias and sudden deaths. And if the person had peripheral vascular disease like atherosclerotic disease of the lower limbs along with the coronary artery disease, we need to continue with low dose rivaroxaban, that is based on the CANVAS study. So low dose rivaroxaban plus aspirin or clopidogrel is having shown that there is reduced events of major cardiovascular events. So what are the various we need to have a vascular protection list for each and every diabetic patient, because diabetes is a multi-system disease. We need to have a multi-system approach, not just diabetes approach. We need to reduce HbA1c, that is reduction of the optimal maintenance of the optimal HbA1c, optimal blood pressure less than 130, maintaining LDL cholesterol less than 100 low risk and less than 70 in the high risk and less than 55 in the very high risk patients. And we need to use drugs which have shown cardiovascular benefit like ACE inhibitors, ARBs for BP, and SGLT2 inhibitors and GLP receptor agonist for diabetes, and along with that, and exercise and healthy eating, that and smoking cessation. And thank you all for this patient listening.
One small update. Kindly scan your QR code on the table for the updated agenda of this day, and we request all the speakers to stick to their time. Thank you.
Thank you, Dr. Ramakrishna.
Yes, sir. Yes, sir. If you screen from the randomized studies, if you screen all peripheral vascular disease patients for coronary angiogram, you will see almost 50 to 60% of the patients had coronary artery disease. If the person, this is like systemic disease, it's not like one system disease. If a person had peripheral vascular disease, you usually have coronary artery disease, you usually have cerebrovascular disease also. From the previous studies, if you screen 100 patients, almost 50 to 60% of the patients had coronary artery disease, whether it may be mild or moderate or severe.
And second small question, there is one injection, tirzepatide. It is weekly injection for diabetes. Is it useful?
I think that is liraglutide, congener.
Sorry? Is it useful?
That
Weekly
has, that has to show cardiovascular safety or benefit only, then only it will come into the market, sir. I am not aware of that injection.
You were saying in Indians there is high risk of cardiovascular disease, but paradoxically peripheral vascular disease is not as common, no, compared to
Western populations.
So what could be you said is multi-system disease, vascular
yes.
pathology. Any particular reasons?
So Asian race itself is high risk for coronary artery disease, sir, mainly. And peripheral vascular disease, I think we don't screen for many patients. So that is the reason for we screen them only if they develop symptoms like already developing some ulcer, or many patients, many educated patient comes after claudication pain after 1 year or 2 years. Recently, I have seen one patient, 42-year, some veterinary doctor from Nagpur. He had claudication pain since 1.5 years, and he recently had stroke while traveling from Mumbai, and he had CVA, and he also had coronary artery disease, and his abdominal aorta is totally occluded. So mainly because of lack of screening. And that too, our patients are relatively younger compared to the Western population.
Thank you, Ramakrishna, for the lucid talk. Due to the less talked incidence of cardiac autonomic neuropathy, many of these events are silent.
Yes, sir.
So, what kind of screening test we can use in a symptomatic patient because of the cardiac autonomic neuropathy? Many of these events are silent. What is the role of fractional flow reserve in detecting the lesions?
Fractional flow reserve for coronaries will, based on the coronary anatomy, we will see that, sir. It's not for everyone.
So, what kind of screening tests we use, because these events are silent?
We need to apply it for a large majority of the patients. We need to have a non-invasive test first, like at least a treadmill test, ECG, echo treadmill test every once in a year, so we can detect at least some majority of the asymptomatic patients. FFR is for mainly for if the person had borderline lesion, we will use that test.